And all right. Hello, everybody, and thank you again for joining us for another one of our wonderful specialist educational seminars. Today, we have the wonderful and lovely Dr. Susette Sowden, who is a clinical psychologist. Her work involves treatment for anxiety and mood disorders, post-traumatic stress disorders in particular, dissociative disorders, eating and sleep disorders, somatoform disorders, sexual disorders, substance use, adjustment, schizophrenia, and personality disorders. She has extensive use working with people across these areas and assisting with anger management and personal issues. And she is a highly experienced independent medical examiner working in this field for many years. We are proud at MAG to have her as one of our wonderful specialists and very excited about this talk today on psychological trauma with physical injury, which is a very, very topical issue within our industry now. So without further ado, I will hand over to you, Doctor, and thank you all for joining us. May I ask, now there's quite a few people on, that you keep your microphone muted so that no noise from your home or workplace interrupts the talk. And then at the end of the session, there'll be the opportunity to ask some questions. Thank you so much.
Thank you very much for that kind introduction, Michelle. Can you hear me?
Loud and clear.
Okay, good. Okay, we know the topic. Now, I'll launch right into it. Workplace situations is really what we're looking at today. With psychological trauma, we're normally looking at a primary psychological injury, such as PTSD, along with the physical injury itself, which is at the time of the trauma occurred. Now, the secondary psychological injury only occurs psychologically where there isn't PTSD at the same time. Okay, and we often refer to these as adjustment disorders with anxiety or depressed mood, or somatoform disorders. Now, if there's a primary psychological injury, for example, a person has a very traumatic injury at the time of a traumatic event at the time of the injury and is fearful for their life, there may actually be two separate work cover claims. So with PTSD and physical injury, there are normally two separate work cover claims, and that's important to recognise. Now, the primary injuries, as I've noted, will be normally post-traumatic stress disorder and physical injury. I'd like to mention three case studies that I'll be alluding to throughout the talk. They're all males. One is, the first gentleman is 33 years of age, and his injury occurred in May 2017. He was a fitter and machinist in the Wodonga, actually, abattoir, and grinding piece of stainless steel, the 9-inch angle grinder, a bit of steel fell off, went straight into his face, caused major bleeding, nearly bled to death, very fearful for his life and major injuries. The next, he's still not working. The next gentleman is a gentleman who is 39 years of age, and he was working with a livestock exchange group and was the assistant manager for over 12 months, very experienced fellow. He had actually presented to me prior to the workplace injury that occurred in November 2018 for OCD and for trauma-related incident in coming across a death on a road. Very brave young man. And he was working on the day with one of the bulls. The bull seemed to be temperamental. It charged him. He tried to get over the fence, rammed into himself twice, and he has significant lower back injuries from the ramming and hip injuries. The third case is a gentleman who is Australian, but he is a Sikh man from India. So he's interesting because of the cultural implications. His injury occurred in December 2017. He was working as a disability support officer with very violent residential clients, and there was an attempt to kill him, choking him. He found himself with significant ankle and lower back injuries. All these gentlemen have been diagnosed with PTSD and major physical injuries with chronic pain, and I'll be alluding to them throughout. Now, the aims of today's session is to go through the issues pertaining to chronic pain, then PTSD, and very importantly, looking at the mutual maintenance model, explaining the association between the two, how the PTSD symptomatology reinforces the chronic pain and how it's very difficult to move beyond that without appropriate treatment, and then the implications for treatment. What does pain mean? Pain is an unpleasantary sensory and emotional experience associated with actual and potential tissue damage or described in terms of such damage. Now, the diagnostic criteria have changed. We used to refer to a pain disorder, and that was in DSM-4. It's moved towards the somatic symptom disorder in DSM-5, and that looks at a disproportionate and persistent thoughts about the seriousness of the injury, so they over-focus on the injuries, high levels of anxiety about the injuries and what it means, and excessive energy devoted to the injuries. We often refer to them now, if the psychological injury is only a secondary injury and there's no trauma, we normally diagnose it as an adjustment disorder with anxiety and depressed mood. Now, in terms of pain, understanding pain, it's useful to look at the concepts of acute versus chronic pain. And acute pain occurs really at the time of injury and may take up to a month or so to resolve. It's related to an identifiable noxious event like breaking your leg. The chronic pain occurs really after 1 month or 3 months and is chronic and lasts for a long time, often years. We talk about nociceptive and neuropathic pain. The nociceptive pain is the pain that relates to the actual noxious event, the physical injury itself. The neuropathic pain is more a nervous system injury, and we'll often talk about a chronic pain disorder in relation to neuropathic pain, or it could be peripheral neuropathy and so on. Now, in terms of prevalence, I'll just skip through this. Chronic pain impacts upon that percentage of the population, which is quite high. It predominantly manifests in this age group, 45 to 64 rather. 84% of all GP visits are prompted by pain, interestingly. Huge amount of money spent on it. Now less than 10%, these were studies in America, less than 10% of the chronic pain population consumes more than 70 to 80% of the resources. Sorry. And there are huge relationship with MBAs and work-related injuries in relation to chronic pain. Comorbidities. Now, interestingly, just down the bottom, 1.7 to 10% of chronic pain disorders like the somatoform disorders are associated with PTSD. A lot of chronic pain is associated with other disorders such as substance abuse disorders, panic disorders, and a lot of association with personality issues. Now, in terms of coping styles, right, we talk about 3 coping styles. In therapy, our aim is to develop adaptive copers. And this is a lot of pain management work I do with people who have had chronic pain associated with an adjustment disorder as a secondary injury, but not necessarily the PTSD. And you're looking to have these people experience lower pain intensity, less pain interference, and less affective or emotional distress. So they get on with their lives, they just manage the chronic pain. Interpersonally distressed folk who receive very little social support. Now, the dysfunctional copers are the interesting group, as they are normally related to the sufferers of post-traumatic stress disorder. Chronic pain sufferers high in PTSD evidence greater physical injury and impairment, greater psychological distress, and greater use of maladaptive pain coping strategies than chronic pain sufferers without PTSD. So you'll see a lot of folk with the PTSD falling into this group. Now, current theories, just to give you a little bit of theoretical insight. I normally relate to the CBT theory, but the operant theory, there is quite a lot of overlap between them, of course. The operant theory looks at the role of reinforcement. It can be positive reinforcement So I'll do all the chores for you so you don't have to worry about anything. So you're getting reinforced to experience more pain. Or the negative reinforcement, that is, if your pain persists, you don't have to have usual occupations or responsibilities that you perceive as unpleasant. Maybe going back to work, okay? Now the CBT is, I think, a better way of looking at it, but there's overlap, of course. You have the perspective of the biopsychosocial and psychosocial phenomenon. I'll talk about that. That's the interaction between the nociceptive sensory stimulation, like the broken leg or the face being lacerated at the time of injury, and psychological factors, thought, emotional, behavioral, and a lot of what goes on here is catastrophizing. This is going to go on forever. There's no relief from it, and very importantly, socioeconomic and cultural factors. I want to read you a letter, part of a letter that I wrote about this very, very nice man in his early 40s. It's very difficult to shift him. He was the gentleman who was the disability support worker who was nearly killed by a very violent offender who attempted to choke him around the throat. And he fell and he sustained major injuries. And this will give you an idea of how difficult it is sometimes to shift these people. So I'm going to read a paragraph from a letter I wrote to the doctor. The third component of the session was fascinating. This gentleman is a Sikh, and he really responded. Well, he really responded well to my work because I have 2 daughters, both of whom have married Sikh men. So I have a lot to do with the Indian culture. And he really appreciated my understanding of the culture from India. He's an Australian, but he still has that heritage. Okay, I had the opportunity. Okay. The gentleman was outlining to me the 5 castes in India. I won't go into them because they're very specific Indian names. This gentleman belongs to the 2nd caste, which is the warrior class, and they're the people who will fight and kill and join the military. So we have here a gentleman who is a warrior. And I noted to the doctor, I take this very seriously, as I see this in particularly one of my son-in-laws. And here he is feeling physically broken and psychologically flawed. So we're slipping here into the PTSD. It does not sit well with him, and he finds it deeply difficult to come to terms with what has happened to him. I'm of the opinion that future clinical psychological work needs to work within this framework. I noted my high respect for the gentleman, and in which he found himself totally out of his depth within a very violent workplace environment, and a workplace environment in which there was also a lot of the social decay in our society was manifested as well. And he really, really deeply appreciated my understanding of where he was coming from in terms of a cultural phenomenon. Okay. And that's been so he relates well, which is very helpful. The interpretation of pain is extremely important in the CBT theory of pain. In therapy, I genuinely attempt to get people. I was doing this morning actually with a very nice man who was actually in his 50s, trying to get people to move away from the concept of pain more to the concept of sensations. And I talk to people, no, you don't have pain. It's a dirty word. It's about a sensation in your body. And I'll talk to you about how I try to move them towards this. If they interpret pain as a really bad thing, as many of them do, it's going to be very, very hard for them to move on. A key aspect in the CBT work, of course, is the avoidance. Oh, sorry, what's happened there? The avoidance maintains pain. There is huge levels of avoidance in chronic pain sufferers. Okay, and I'll look at the overlap between the pain sufferers with the PTSD shortly, because the avoidance of pain goes with their concerns about anxiety associated with the pain. Most of the pain that these people experience is not actually the nociceptive stimulus itself. It's actually the anxiety about the pain. It's the fear of the pain. Then they become highly tense. That aggravates the whole sensation, and so it becomes very reinforcing. And it's breaking that, which is extremely important. Overview of problems caused by chronic pain. I'll just go through it very quickly. Reduced activity, which is avoidance. Physical deterioration. One of the worst things you'll ever do if you have a pain sufferer is to avoid moving. It's extremely important to have appropriate interventions like exercise physiologists, physiologists who can actually work with these people within the medical restrictions. Okay, and they understand this condition, so they're very good at working with them. The unhelpful beliefs and thoughts like, this is a terrible situation, I'll never recover, why did it happen to me, drives into the depression, helplessness, irritability, excessive suffering. Repeated treatment failures. I'm sure that many of you have seen this, where they have surgeries and nothing seems to improve. That drives that. A longer term use of, I can't talk about this much because it's not in my area of expertise, but I see this a lot. People becoming overly dependent upon their medications, and part of the pain management programs are actually designed to get them off their medications. And of course, there's a huge thing for people, particularly if the males, and today females, many women carry the financial load for families today, loss of job, financial difficulties, terrible situations for people, terrible. And particularly where they have been very proud net contributors for many decades, and they've had that sense of pride, to be in this situation is very hard. How pain becomes the maintenance of pain. We've spoken about reinforcement. It doesn't help at all to reinforce pain sufferers. Oh, you poor thing. No, not a good idea at all. It needs to be an attitude of, well, it's here. You need to accept it. We need to move on. It's a sensation. You're be grateful to be alive. Okay. Pain-specific beliefs and reasoning biases. Catastrophizing is very unhelpful. And you see this with so many of the people who don't cope well with the pain normally, and these are the dysfunctional pain copers. Okay. Avoidance and other coping strategies. We've alluded to this already. Avoidance of situations where the injury occurred, avoidance of the pain itself, where people become housebound and bedbound, is really unhelpful. All it does is drive the anxiety, then you have fear of the pain, and then it becomes worse and worse and worse. Also, what can be very difficult is when people have an anxiety, a predispositional attitude, predispositional tendency to anxiety. And you'll hear me talking a lot today about the fear of fear. And so they'll have the anxiety, they'll have the pain, then you're receptive, then you'll have the anxiety about the pain, then you'll have, and that's fear, and then you'll have the fear of the fear. So you've got 3 levels you're dealing with. And so that really is a maintenance model. And that's where the psychoeducation is extremely important. Okay, now I'm going to move into the component of PTSD. And as you'll find later on in the discussion, what's interesting, there is very little research on the interaction between PTSD and chronic pain, and yet this is often a presenting feature in Workcover. There's plenty of research on PTSD, plenty of research on the somatoform disorders and the adjustment disorders and the management of pain, but not on the interaction between the two. And this is a very interesting area indeed. I'll go through, first of all, the diagnostic criteria for PTSD. Most of you have probably come across a lot of PTSD. You did exposure to a traumatic event where your life is in jeopardy, or you've seen somebody dying or whatever. Intrusion symptoms are very symptomatic, where you'll have a reliving either in nightmares or flashbacks of the incident occurrence, like you're actually back there. And then you'll have this intense physiological reactivity, and it'll be very serious panic symptoms and psychological distress. You can imagine what that does to the pain experience. The avoidance is a key feature of PTSD, which is a very maintaining feature of PTSD. They won't want to face up to the actual traumatic incident itself. So a lot of the work that I do with sufferers of PTSD is get them to really face up to the incident, and then they have to sit with the intense physiological reactivity while maintaining eye contact, and that is extremely difficult. And they have to be in a very, very safe environment to do that. Invariably, what goes with PTSD, negative alterations in thoughts, like it was my fault, I was to blame, why did I do this? And there's a self-punishing aspect. I'm guilty for this, look what I'm doing to my family. Alterations in arousal and reactivity, poorer memory, a lot of startle response, hypervigilance, a lot of sleep disturbance. Duration, it goes on and on and on. More, you've got to have PTSD, you've got to have the symptoms for more than 3 months, but unfortunately they often go on for years. Functional significance, invariably there tends to be severe to extreme functional impairment. Exclusion, feeling very excluded from their former lives. And what's very important here too is with dissociative symptoms, where people have dissociative symptoms at the time of the trauma, like for example, the steel is cutting into your face and cutting the major bloodstreams and you're bleeding to death. Where that person actually leaves their body, which is the concept of depersonalization. And this occurs where, and it occurs non-consciously, and it's and dissociation is an escape where there is no escape. So the brain does it automatically. And where the person leaves their body at the time that they're bleeding to death, or at the time that they're dying as they're being strangled to death, or at the time when they feel their hips being crushed by the bull, crushing the hip of the human being, the PTSD becomes far more problematic and it's a lot harder to get over it. So we talk about PTSD with dissociative symptoms, namely depersonalization and derealization. The prevalence of PTSD, these are some American figures. What you have here is slide 16. The prevalence, you'll see the prevalence in motor vehicle survivors, assault victims, and so on. Comorbidities with PTSD, this becomes a more difficult issue, of course. 80% tend to have, this is with the PTSD, other psychiatric disorders. Often there's depression, OCD, phobias, panic disorders. Interestingly, the chap that the 39-year-old chap who was attacked by the bull, he's very interesting. I was working with him back in 2015 prior to the 2017 incident with OCD tendencies. He responded very well to the therapy. Then he presented again in, I think, about 16, where he'd come across the death of I think it was a motorbike victim. It was very, very difficult for him. So he had the comorbidities, but they were pre-existing, but he'd managed them very well because he'd gone had a chat with me about management. Pain is a commonly reported symptom, highly comorbid, which is the topic of today's discussion. 80% of military veterans satisfy the criteria for chronic pain. So you'll see a lot of folk in the DVA system with PTSD and chronic pain, a lot of firefighters and so on. Now, the mutual maintenance model, explaining the association between PTSD and chronic pain. And this is very important. We're now up to slide 20. Okay. Predisposing factors. You're normally looking here at family history of psychopathology, people who are predisposed to PTSD and pain, a bit like the 39-year-old, but he is an interesting fellow because with the work with him, I managed to get him to be an adaptive coper, not a dysfunctional coper, but it still became too much for him and he's now not working. But I'll talk about that later on. So you've got the predisposing, then you've got the precipitating factors where you have the, for example, complex regional pain syndrome, and that goes with the physical injury and the PTSD. And the perpetuating and maintaining factors, and we'll talk about that in detail shortly. There's a lot of overlap between people with PTSD and chronic pain. a lot of overlap in the symptomatology, and these include very heightened anxiety and hyperarousal. The avoidance behaviours are very prominent in both PTSD and chronic pain sufferers, but when you put them together, the avoidance becomes very prevalent. The emotional lability, the emotional dysregulation in the PTSD, and the depression and so on in the chronic pain. Elevated somatic focus, which is symptomatic of both. Hypervigilance and attentional bias. There's a huge level of attentional bias in both chronic pain sufferers and PTSD sufferers to the actual pain and to the trauma itself. Startle response during states of negative affect, which of course triggers the pain. Okay, if they see a bull, that triggers, or they come close to the bull that rammed into them, that stimulates the startle response, aggravates the pain, and so on. And dysregulation of stress responses and pain modulation. Okay. Pain has been found to be associated with poor psychological outcomes. So these people, you've got to be very careful with these people. They do tend to have poorer outcomes if rather than just simply having post-traumatic stress disorder or simply having chronic pain from a physical injury, workplace physical injury, where you've got an adjustment disorder and you have to deal with medico-legal issues. I'll look at briefly at all these, but that they tend to go together. The PTSD, distress, pain, and I've talked about these, attentional and reasoning biases, highly anxious reminders of the trauma, avoidance, and so on. Okay. Attentional and reasoning biases, the PTSD sufferers tend to be very focused on the actual trauma itself, so they become highly avoidant of going back into the area where the bull was, highly avoidant going anywhere near a residential home, highly avoidant of going back into an abattoir or doing work similar to the work that was being done at the time the major arteries in the face were cut. Now, what's interesting, the pain stimuli itself becomes a trigger for the intrusive symptoms. This is very important. And it's actually studied at a neurobiological level. So when you experience more pain as a result of the incident, like the hip pain, that will then trigger the intrusive reaction, the intrusive thoughts, which then result in the physiological arousal, which then exacerbates the experience of pain, and the person becomes very dysregulated and almost incoherent. It becomes very hard. Okay. So with both of these conditions, there's this amplification of pain, which is the reminder for the trauma, because as they felt their hips break, they realized that they were going to die, or they thought they were going to die. As their face is being cut severely and they're experiencing extreme pain, that's also the time when they realize that they're probably going to die. Anxiety sensitivity, which goes with the post-traumatic stress disorder and the pain, is the catastrophization of the physical sensations. I'm going to die. I'm going to have a heart attack. I'll never get over this. And it drives much vulnerability. Here we are. Reminders of the trauma. And we've spoken about this. So you see the bull, you see the residential home, you see the equipment, or you see the abattoir. Triggers the intrusive memories and the nightmares. You wake up with the nightmares with intense physiological reactivity. The pain is highly significant at the time because that triggers the pain as well. So the pain triggers the PTSD symptoms. The PTSD symptoms trigger the pain. Chronic pain feeds into the process, the pattern of mutual maintenance. And of course, then you get all these disabilities. And people who've been very active in the workplace find this very, very difficult. Very difficult indeed. Avoidance, we've talked about avoidance. Avoidance may be protective in the short run, at least I'm not experiencing pain. In the longer run, it is becoming highly maladaptive and makes the whole situation a lot worse. Okay. They'll often, with the PTSD and the pain, they'll do everything they can to not think about the trauma, which is the cognitive avoidance, which only serves to make the whole thing worse because you're not introducing the concept of desensitization. And we'll talk about that shortly. Of course, what often becomes comorbid, depression, reduced activity levels, which makes everything far worse, anxiety and the pain perceptions, and the adaptive coping strategies become much poorer. And we go into the concept of extreme to severe to extreme functional impairment, which is very hard. Go down here. Now, I think this is the area that I find more interesting than the theory as such. It's actually the implications for treatment and what you do about it. And this is what my life has been immersed in for several decades now. And it is, these are very, very good people, very interesting people. And most of the people I work with want to deal with the situations. Of course, there is also the reinforcing situations in relation to the medico-legal processes. This is not one of the people part of the case study, but decades ago I worked with this very, very nice ambulance officer, and he was the head of a local large ambulance office with many ambulance paramedics in there. And he had a major motor vehicle. It was a motorbike accident on the way to Sydney. He was going to a function in Sydney. A truck caught him, major physical injury, major PTSD. Now, what was very reinforcing for this man, and I understood totally where he was coming from. He was the provider. He wanted to provide for his wife. He did not want the therapy to interfere with his level of disability, so that he would actually receive maximal financial remuneration via the Workcover system. It's not my place to criticize that. I have no place to criticize that, but our job is to get them better. So there's this tension in our work in getting them rehabilitated, but they're coming from the point of view of wanting to provide for their families. And it's not my place to really buy into that. But that is something that does plague the Workcover area, and it's well recognised. Aims of assessment, and the assessment's meant to be fairly comprehensive, and the IMEs do this very well. History and so on. I won't go into all those. You can read those later on. Methods of assessment. It's you need triangulation of different sources of data, background information. There's normally a lot of review of other reports and so on. The clinical or forensic interviews, the mental status examination, and the formal psychological testing. Two tests that I use quite a bit include here we are, aims. Yes, what have I? Background, okay, yes. Two tests that I use for the PTSD, I haven't listed on here, is the personality assessment inventory, but these are very sensible. I've got here, there's the PAI, sorry. Trauma symptom inventory, structured interview. The PAI is probably the better instrument to use. For pain, not listed on here, I use the pain patient profile. And that looks at 3 variables. And what I like about it, it's related to actually the it's normed against the pain population, and it looks at the symptomatology and anxiety, depression, and somaticization, which we've talked about. This heavy over focus on the symptomatology. Now, the treatment implications. I'll just go down here. Sorry, are very interesting. Treatment. Okay. Make sure I'm onto the right one. Okay. Oh, yes, the treatments. This is outside my area of expertise, but the psychiatrists do a lot of this. And my responsibility is to work with that appropriately. Okay. I tend to use what I tend to focus on in treatment for these patients, you must have a strong therapeutic alliance, because if they don't relax with you, you can forget your treatment. It doesn't matter what modality you use. Okay. So you need to modify that, and I have a lot of emotional, so people feel very safe with me. There's a strong therapeutic alliance. There's a lot of secure attachments. That's very important, and emotional safety and security. So it's a safe place for them. That's very, very important. Okay. So you tend to modify these strategies to treat both the PTSD and pain, and you've got to do a lot of psychoeducation that looks so people are aware of the links between the PTSD and pain. That's very important. Anxiety sensitivity, interoceptive exposure is a very interesting strategy. The avoidance, you're dealing with imagery exposure now, and all imagery exposure and rehearsal exposure for nightmares, behavioral activation, getting them to do things, and of course, the medications. The psychoeducation, people have a right to know about their condition and the links between the pain and the PTSD. And we've looked at those. Okay. And what's very important for these people to understand is that their chronic pain is made worse because of the PTSD symptoms, and the PTSD symptoms are made worse because of their chronic pain. When they see the link between those and you give them insight into the neurobiological component, they then realize the importance of taking a step-by-step approach to managing pain and PTSD, and you might swap between the chronic pain and then go into a symptom of the PTSD, then you go back to chronic pain, then you go back to managing a symptom of PTSD, but you must always do that with permission of the patients. They have a right to know exactly what you're doing, and I'll say, this is what we're doing today. Do I have your permission to work on this? And they say, yes, that's okay. Okay, and off we go, unless there are a lot of the therapy, of course, is dealing with day-to-day things that crop up, like difficulties with marriages, and the partners are getting sick of it. The children are playing up and so on. Now, anxiety management techniques. What I use a lot of, and this is important with the anxiety, because the anxiety pervades both the PTSD and the chronic pain. It's in both conditions, okay? So you're giving them some upfront anxiety management techniques for both conditions, okay? What's important initially is to teach them how to evoke a full relaxation response, not because the relaxation is a major strategy in and of itself, but it is a sub-strategy that you use after the habituation, which you'll see down the bottom here, okay? Now, with respect to, actually, I did it with a gentleman this morning. He was a very nice man. He was a man who only suffered chronic pain, not trauma symptoms. He was a chap who delivered large amounts of fuel for a large company. And he was climbing up a ladder within a cage to fill the farmer's tank with fuel. Down he fell, major shoulder injuries. And here he was such a sweetheart. He's lying on the ground, on the grass outside the caravan. This morning during therapy, it was done via telehealth. And he's engaged fully in the autogenic relaxation technique that I talk about. And I'm doing it with him, and he's bringing his tension, the muscular, the bodily strain in his body down from the 7, which is the maximal level of anxiety or strain, down to about 4, and we'll eventually get him down to 2. And here he is focusing on these sensations within his body with the pain. And I'm asking him to actually stop using the word pain. He's no longer allowed to use that. It's a sensation. And you don't have to be scared of a sensation. So he'll feel the tingling in his fingers, the tension in the shoulders, and he has to let go of these, feel them. And in a more relaxed state, when you actually feel the actual sensations associated with the actual point of injury, and you get rid of all the anxiety associated with the pain, the actual severity of the pain significantly reduces. It becomes far more manageable. So you're getting these patients to really evoke the full relaxation response, to try and address their fear of the pain, and then their fear of the anxiety, or their anxiety of the pain, and their fear of the anxiety associated with the pain. So you get them right down into the sensation itself. So they have to focus on the tingling of the tingling in their hands, the pain in their lower back, the pain in the hip, and they're not allowed to use the word pain. It's a sensation. That's all it is. And they relax into it, and they can then start to reinterpret it. I can manage this. And as I say to a lot of these people, irrespective of the PTSD, you can have all the medical treatments you like, or the surgical treatments. It's very hard to get people back to their pre-injury level of functioning. There's always some residual pain associated with the injury. It just is what it is. And so the acceptance component of this is extremely important. Many a time I've said to people, you're trying to run from the pain. Where are you going to run to? There's nowhere to run. It is who you are now. This is who you are now. You have these sensations. You may as well like them. And so if you can target the dysfunctional copers with the pain and move them into a more adaptive coper, it'll be very helpful for them. And at the same time, you're getting them to experience the pain. Now, this is really hard stuff. Out will come the PTSD intrusive symptoms. So you're asking them to focus on the pain. It's not pain. It's only a sensation. And this takes these people enormous courage. If they're in a very nice recliner rather than lying on the grass, for instance, I'm often asking these people for eye contact. I'm saying you are to continue looking at me because the eye contact is very powerful. That will trigger a traumatic memory of the hip crushing as the bull runs into you, as you're feeling blood all over you, as you realize the artery's been broken in your face, as you feel your right ankle or left ankle going and the lower back injuries, as you're being strangled to death. Out will come those symptoms, and it takes huge courage for these people to sit with the memories. And I say to them, you are not to repress them. You are to experience the memories and all the physiological arousal that goes with the triggering of these memories, and they have to have eye contact with me. This takes huge, huge trust. It is hugely emotional. Many a time, and these may be brave police officers, they may be ambulance, these may be the three people I've talked about today. The level of vulnerability in them as they are sitting there experiencing all the physiological arousal that goes with the triggering of the memories as I'm asking them to relax into the sensation. And invariably what happens, and I see this day in, day out with people, as they sit with the physiological reactivity that goes with the triggering of the trauma memories, that is the only way you will ever, ever, ever have desensitization and move on. As I've said to many, many people experiencing severe flashbacks, it's not the flashbacks that are the issue. The real issue is the physiological reactivity, the triggering of the pain or the sensation. It's the fear of the physiological reactivity that is the guts of your presentation. And I'll share something with you. It's interesting. I say, if you ever want to look at the neurobiology underlying this, please read my niece's research. Now, she is the professor of neurobiology, and her name is Natalie Tronson. She's a very, very clever woman. And she's the professor of neurobiology at Ann Arbor University in Michigan. And she does all this work on rats. And she said to me, what sort of therapy do you do? And I told her. And she said, it's extremely hard for patients what you're doing, but it is the only way you will ever change the neurochemistry within the amygdala, which is where all the trauma memories are held within the limbic system. And it's appropriate now that I'm feeling quite sad, because I do feel the emotions of these patients. And they themselves, if they feel that you're in tune with them, they're far more likely to respond very, very well. But this takes extreme courage on the part of these people. It's very interesting work. Now, I'll touch on the applied relaxation training. They learn off by heart the autogenic relaxation technique, where they can evoke the full relaxation technique, and they have to practice and practice this at home. Then what they learn to do too, they learn then to evoke this relaxation response in all kinds of situations, like, for example, if you're standing waiting for a red light to turn green when you're crossing a street, and you use a particular stimulus, it may be the deep, slow breathing, where you're breathing out the concept of the word relax, and they become conditioned to actually evoke the full relaxation response. But that takes quite a lot of conditioning, and they can do it, but it takes a lot of homework practice. Keeping an eye on our time. Imagery rehearsal we've touched on already, and that involves getting them to sit with the actual physiological arousal that goes with the triggering of the memories. And it is hard stuff. It's the only way to get through PTSD. It's one of the key ways. And the concept of avoidance just doesn't cut it if you want to resolve PTSD. Now, the other one too, cognitive, I won't go. So you do the cognitive work on not having catastrophizing and so on. What's very interesting, it's touched on here, in vivo exposure, where they have to gradually go back to the site of the incident. I do require people to go back to the site of the incident, go back to the abattoir, go back to the arena in which the bull attacked you, go back to the residential home where you were nearly strangled to death. And it's a gradual exposure approach. You feel that they'll feel more physiological arousal. They have to stay with it, sit with it, feel the pain, relax into it. Then you go a step closer, and so on and so forth, and you eventually get there. But it takes a lot of time, and it takes a lot of courage. Imagery rehearsal is an interesting one, and we can actually reduce the severity and intensity of nightmares quite well with this. It's very interesting. So I'll get people very relaxed. They then have to go through the nightmare in detail with me at a conscious level. And the nightmares can be all kinds of things. They can be spiders crawling all over you. It can horrific stuff, horrible stuff, what the brain does as at a subconscious level in reinterpreting the trauma is quite fascinating. And so they have to feel the nightmare. They've got to feel the full physiological reactivity at a conscious level. We do that. Then in the session, they then have to have mastery. So they've had the nightmare in a conscious sense. They've felt all the anxiety. They've sat with it. Then they have to go to the notion of mastery. Then at a conscious level, they're allowed to change their nightmare any way they like to have mastery, any way they like. And I'll tell you one lovely instance. This was an interesting one. There was a wonderful police officer I worked with, and her nightmares, she was nearly killed with a fellow who was trying to stab her to death. And of course, the nightmares are the fellow comes into the house. She's alive while she's seeing the children being murdered and their throats slit. And then she wakes up with extreme heightened intensity as she herself is being killed. And she's seen the children being killed. Now, I did this work with her, and I said, now you don't have psychosis. We can't do this with you, young lady, if you have psychosis. So what I got her to do, she had to have the mastery component. We went through all the nightmare and the physio and the habituation and sitting with the trauma. Then I said, you do whatever you like. I don't care whatever you do. Go really primitive. Do whatever you like. Anything you like. And you get rid of all your inhibitions, all your training. Just become primitive. Well, what she did, nightmare, she picked up a hammer and bashed him to death. So that's a good girl. You go for it. But I said, we don't do it outside. You understand that? You only do it in your mind. Okay? So she got that and off she went. And she came back and she said to me, it was fascinating. I was in the supermarket, and previously I was terribly scared of this fellow because he was out of jail by this time. And he was in the line behind me in a country town, waiting to be served at the supermarket. She said after that session, she said, I was no longer scared of him. I said, well, you had mastery, didn't you? And so as they're going to sleep, they're encouraged to have this imagery. It may not be quite as violent. It could be all kinds of things they image. And so that reduces the intensity and frequency of the nightmares. And this takes a lot of practice, a lot of repetition. Interoceptive exposure is an interesting one. We've already talked about this, where you sit with the physiological reactivity. It's very important to have eye contact with these people. They're experiencing heightened heart palpitations. Their hands are sweating. They're sweating heavily in their bodies. They've got very strong pain in their heads. They feel tight, and they have to have eye contact with you while they sit there and they experience every single symptom. And that interoceptive exposure, you're actually buying into it. Because you're in tune with them very much, you're actually feeling it with them. And that's an interesting concept associated with mirror neurons. And they feel it's a sense in which the patient feels very validated by the sharing, so to speak. And that's what interoceptive exposure is. Sleep improvement programs, I think we've gone a little bit over time. And there's other types of things, I won't go into it. We talk about relapse management a lot. And then ongoing evaluation. I'm sorry, I went a little bit over time. Any questions?
Suzette, that was absolutely incredible.
No,
Thank you so much. It was so comprehensive. I've made quite a few notes, and I do have one one observation I'd like to make before I invite people to ask any questions, and that is that statistic that 84% of GP visits are as the result of pain. That is absolutely phenomenal.
That's right. It's a very big thing in our society. And as I say to patients, we want these long lives. And I want a long life. I'm 69. I'm happy to live until 100. But we want these long lives. And that's all very well. But that's often what goes with aging. And injuries. Most of us get injured in one way or another. We play sports and all kinds of things. And 200 years ago, we were deceased by the time we were 40.
Yes. Wow. Look, is there anyone there who would like to ask a question of Dr. Sowden? Yes, here we go. Catherine has asked a question in the chat. 80% of people with PTSD have other psychological disorders.
Yes.
Where are we? Are these disorders pre-PTSD, post-PTSD, and as the result of PTSD?
I think it's all three. It's all three. Like the gentleman, the 39-year-old fellow. He's a wonderful man. He was the one who was attacked by the bull. He had OCD, and I think he did have pre-existing trauma symptoms. He responded very, very well to the trauma therapy I did with him when he came across the motorbike. He saw the fellow die in front of him, the motorbike rider. Yes, there are a lot of people. You're in the workplace. Plenty of people with personality disorders in the workplace. All kinds of pre-existing conditions. It's just. As I say to people, we're human beings. We're a bit messy. We muddle through, most of us. And I'd also often say to people in terms of pre-existing conditions, you've got to remember the workplace is potentially a dangerous place. You come into it, you're all thrown together. You come with these totally different cultural backgrounds, like the Sikh from India, like a hardened, let's say, person on a construction mill who's been, and you see this at the construction sites a lot, the person who's been in the bikie groups, you're all tossed together, And that's why you've got to have these very strong policies and procedures, because you've got to manage all these people. So, of course, people bring all kinds of things with them to the prior to the trauma. And then, of course, with the PTSD goes all these comorbidities like depression, and that particularly with the pain, OCD, they become highly obsessive. Phobia, you see this with car accidents, they become highly phobic of being in the passenger seat or whatever it is where they were when they were being hurt. And then and when you're vulnerable, you've got PTSD, you've got chronic pain, it's easier to become more easily injured. Your wife leaves you, your husband leaves you, people are sick of you, because when they go on and on about these conditions with the catastrophizing, they drive people away. That gives rise to other disorders. So you've really got to be onto it with these people. It's very hard.
Yeah. Now, look, there's another question that's come in. This may be outside of your scope because although you are a doctor, you are not a medical doctor.
No, I'm not medical.
The question is, has propranolol, which is the anesthetic, I believe, does that have a role in PTSD?
Look, I was asked that by my supervisor recently. I gave this answer, and I think this is the way I see most medications and even treatments. Ultimately, you can have whatever treatment you want. The best medications, you can have the best this, the best that. I know that they're introducing some form of stimulants for PTSD, which is maybe what this relates to. Ultimately, it comes down to how much you want to get better. Ultimately, that's what happens. Like the fellow with in the bull ring, he was a fascinating man. He did not want to leave work. Oh, wonderful country fellow. He saw himself as a provider, young children, a wife, and so on. And we actually got him to be an adaptive pain coper. And yet, really, according to theory, he shouldn't be. And so what became more prevalent for him was the PTSD. I was talking to him about my concerns about him being at work. Oh, goodness me. Then he had seizures at work. And I said, you've now got a conversion disorder. You've got to get assessed. Off he went to a psychiatrist. Yes, he's got a conversion disorder, which is very, very severe trauma. It's what soldiers get when they're in World War I. Friend over there's got no leg. That one's lost his head. You're lying on the ground, no injuries, and you're unable to move. There's just complete paralysis in your body, or it is maybe a seizure of some kind. Wow. So this fellow was determined to get back. So other people, and it's not my place to criticize, it is not my place. Some people like to maintain the conditions.
Well, it's a safe place, isn't it?
Well, yes.
Now, I've just got a quick question here that follows on. We're going to have to wrap up soon, but this question is, I have seen an increased use of ketamine infusions for PTSD and chronic pain. What are your thoughts on this?
Look, I've worked with a lot of people who have ketamine infusions. I can't answer questions like this. I'll just get into trouble. It's not my place.
Fair enough. Look, we've gone a little over time. I would just like to say thank you so much for one of the most interesting, informative seminars that I have listened through. I thank everybody for your time and joining us for this session. The recording will be sent to you fairly soon afterwards and will, of course, be available on our YouTube channel to watch. Dr. Sowden, that was fascinating.
That's very kind of you, Michelle. Thank you.
You're very welcome. Thank you so much for your time and expertise. I would urge you all to revisit the seminar and the slides when you get them. And if you have any further questions or anything you would like to direct, please email me and I can speak with Doctor about that if you have anything particular that you'd like to ask. Don't forget that we have many wonderful specialists. We do seminars all the time, that Dr. Sowden is available for booking through us to assess your clients. And we look forward to working with you in the future. Go forth and have a great rest of the day, everybody.
Thank you, Michelle. Thank you very, very much. Bye-bye,
Welcome.
Michelle. Bye-bye.
Bye-bye.
Bye-bye.